the last day of my fellowship training in pulmonary and critical care medicine in 2008, I became a critically ill patient. So I went from being a physician and really at the end of my training thinking I knew something about what it meant to be sick, to being a patient in a hospital bed and realizing that I didn't understand what a lot of my patients had faced and what they'd been through. I was 7 months pregnant and I had sudden onset of very severe abdominal pain. What I didn't know was in that moment, a tumor that we weren't aware of in my liver had ruptured. And it was a very brisk bleed. It was like an artery being severed. And so I was bleeding very quickly into my abdomen. Within the first 2 hours, really, the blood loss had emptied my heart and veins and arteries entirely, and I'd gone into shock. The baby died. And I went into multi-system organ failure. So my liver was very dysfunctional. My kidneys failed. I had to be put on what's thought of as life support, a ventilator. And I had emergency surgery to evacuate the baby and try to find the source of the bleeding. So that initial night when that pain started turned into an ICU course that was complicated by every organ dysfunction, as well as a stroke that left it difficult for me to walk, and multiple procedures to get me well. There were a lot of things that surprised me during my hospitalization, starting from that first night when I was in the OB triage area, and one of the obstetrical residents approached me with an ultrasound machine when my lab values were very deranged to check on the health of the baby. And as he put the ultrasound probe on my abdomen, I could see the images, and I was an ultrasound trained physician. And I could see that the baby's heart wasn't beating, and I must have said that out loud because he said, "Can you show me where you see that?" And I thought in that moment that he wasn't seeing me as a patient. He wasn't seeing me as a mother who was in shock, who had just lost her baby. His perspective was really aligned on himself. And I recognized our training in that. We're trained to see disease. We're not as well trained to see suffering when it's in front of us, and we certainly aren't trained to have the skills to respond to it. I woke the next day when I was on full support, really unable to communicate. And the first lucid thought I remember having was hearing the team in the hallway who was rounding on me. And I wanted to listen because I wanted to know what was wrong with me. And I heard them report my case in a very medical way, 33-year-old, presumed HELP syndrome, post-op, day 3, intraoperative observation of a large subcapsular hematoma, these medical terms that I was following loosely. But then I heard the resident say, "She's been trying to die on us." And it made me really angry because as a patient in the bed, I was not trying to die. I was actually trying very hard not to die. And I felt that by saying that, by disclosing that in that way, he was declaring our relationship adversarial, that we were on opposite sides, that I was trying to do something and he had to try to prevent me from doing it. And as angry as I was, I recognized myself in that statement. I knew I had said that exact same thing as a critical care doctor. I had told my colleagues, this patient's been trying to die, perceiving myself as a barrier against their transparent goal. And I felt ashamed about that because I had never thought about that perception as a patient of what it meant to hear your doctor describe you that way. And, I really wanted to not do that anymore. We started offering training programs. Our sessions are called Clear Conversations, and we use a group of highly skilled improvisational actors from the city of Detroit. And they serve as our patients or our patient surrogates. And we train physicians in real time in experiential learning in difficult conversations. You know, the first time someone has to tell somebody that their loved one's dying shouldn't be in real life. We use simulation training everywhere else. We use it for surgery, for procedures. We should look at conversations in the same way. They're high-risk events. We have the opportunity to impact people and how they cope with these situations. So we began doing these trainings, and we really saturated areas of the hospital that have these conversations a lot: critical care, palliative care, oncology, the emergency room. We really want this to spread so that it becomes the norm, that all physicians and care providers are oriented to empathy and to the patient, and they listen actively and reflect that listening back to the patient. So when the health system saw the work that we were doing in the hospital, they recognized the value in it, which is amazing and visionary, and they really wanted to spread it as a new cultural norm, to make this the value that is embedded in our health system. And they recognized the points where there were weaknesses. They reframed new employee orientation so that all employees hear where we fail and where we succeed. You know, there were some great successes that came out of my hospitalization, and to be able to share those with people who might not even feel that they were part of the care team, it really tells people that they have a purpose here at Henry Ford, that they have more than a job, that it's a mission.